There's actually some very exciting new things in allergy and immunology besides just saying Zyrtec. And it is on hereditary angioedema. Brand new breakthrough medications. Besides the usual things like anaphylaxis. Now, anaphylaxis, what's the difference between an allergic reaction and anaphylaxis? And the answer is hemodynamic instability. Well, an allergic reaction is a hypersensitivity reaction. Allergic reaction can be a rash, but what's the difference? Life-threatening. What makes it life-threatening is not the eyeballs. What makes it life-threatening? Chest pain, shortness of breath, hypotension, confusion, means you're not getting enough perfusion. What makes it anaphylaxis is respiratory and blood pressure problems. That's what makes it anaphylaxis. Now, you will become allergic to things like bugs, drugs, and foods. Bugs, drugs, and foods. Bugs, drugs, bugs, insect bites, drugs, medications, and certain foods like these nuts or shellfish. So that can be an allergic reaction or anaphylaxis. Well, how do you tell the difference? Chest pain, shortness of breath, hypotension, confusion means you're not getting enough perfusion. Now, the medications that cause you to have an allergic reaction or anaphylaxis, penicillins, rash, anaphylaxis, sulfa drugs, rash, anaphylaxis, penicillins, sulfa drugs, allopurinol, phenytoin, quinidine, rifampin, penicillin, sulfa drugs, quinidine, allopurinol, phenytoin, rifampin, lamotrigine. Well, aren't those also the same drugs that cause you to have drug-induced hemolysis? Penicillins, haptens, sulfa drugs, G6PD, and drug-induced hemolysis. Penicillins, sulfa drugs, allopurinol, phenytoin, rifampin, quinidine, and lamotrigine. Aren't those the same medications that cause you to have allergic interstitial nephritis and an EO here and an EO there and an EO in my underwear? Old MacDonald had nephritis. EO, EO, EO. Penicillins, sulfa drugs, allopurinol, phenytoin, rifampin, they are the same medications. So the things that cause you to have a rash, penicillin, sulfa drugs, allopurinol, phenytoin, quinidine, lamotrigine, are the same things that cause drug-induced hemolysis. Penicillin, sulfa drugs, allopurinol, phenytoin, quinidine, lamotrigine are the same things that cause allergic interstitial nephritis. Penicillin, sulfa drugs, quinidine, lamotrigine, rifampin. So you don't have to memorize them separately. You can say they're all the same thing. Rumi Molevi says, I am like a flute with a single note tuned to 200 creeds and beliefs. So allergies are a single mechanism that can affect your skin, your respiratory tract, your blood pressure, your kidneys, and hemolysis. Now, there are certain drugs like calcium channel blockers. They don't cause a rash. Calcium channel blockers, they don't cause anaphylaxis. Calcium blockers, they don't cause drug-induced hemolysis. Calcium blockers, they don't cause nephritis. There are medications like beta blockers, SSRIs. They don't cause a rash. They don't cause hemolysis. They don't cause nephritis. So there are certain medications that don't affect any of them. So you see what the medications are like that cause anaphylaxis and rash, nephritis, and hemolysis are like certain people. There are certain people that are sort of chill, relaxed, and cool and easy to be with no matter what part of the world they live with. Hey, baby, aapke se hey. And there are people who can be annoying on 5 continents and Antarctica. And no matter where they go, including cruise ships, it's like you're irritating no matter where you are. So such it is with the medications that cause anaphylaxis. Penicillin, sulfa drugs, allopurinol, phenytoin, quinidine, lamotrigine, all of them. Now, hemodynamically unstable like hypotension, tachycardia. What is the next best step in the management of this patient? from this anaphylactic reaction? And the answer is the next best step in the management of the patient is epinephrine. Now, epinephrine, remember, step 3 does not ask you the dose, but it does use the route of administration. So it's intramuscular, it lasts longer, and has an effect. Steroids work, but they take how long to work? They take 4 to 6 hours to work. So steroids, just like it is in asthma, take 4 to 6 hours to work. Epinephrine works instantaneously. If they're hypotensive, if you give them fluid. And antihistamines. Which antihistamines? Ooh, which antihistamine? Because you can't just order H1. You have to say, oh, diphenhydramine hydroxyzine. Now, yes, they're sedating Benadryl. They're sedating Atarax. But they're the ones when you're hemodynamically unstable, because it's better to be alive and sedated than dead with no sedation. So these antihistamines are strong, super useful when you have anaphylactic reactions. CCS, computerized clinical case simulations, does not allow you to even order doses, but you have to know the route of administration, and that's why intramuscular is a big deal. The name of the medication and the route. So epinephrine causes constriction by causing alpha-1 constriction, constricts your blood vessels. Epinephrine also works on beta-2 stimulation. So beta-2 stimulation dilates your bronchi. Why not inject norepinephrine? Well, we don't have really injectable norepinephrine, not as an intramuscular, and not as a subcutaneous. So beta-2 stimulation dilates the bronchi, but steroids will work, but after a couple of hours, and they increase vasoconstriction by recent corticosteroids. And for 50 years, we've been saying, hey, do steroids help decrease mortality in sepsis? Do they decrease? Because they seem to, because they raise the blood pressure. Now, the increase of blood pressure with steroids, there is an effect of increasing aldosterone-like effect, but that's slower. The immediate effect is that if you give corticosteroids, they increase the physical number of alpha-1 receptors, and alpha-1 receptors cause vasoconstriction. So leukotrienes is one of the main vasodilators and also bronchoconstrictors. So steroids will get rid of the leukotrienes that will cause vasodilation and bronchoconstriction. Now, the difference between this type of allergic reaction, the difference between these types of allergic reaction and angioedema is the difference between right and wrong, meaning angioedema, like hereditary angioedema, things with minor phase trauma or ACE inhibitors, the big issue is that angioedema, hereditary angioedema, little minor trauma and your face explodes. Little minor trauma, you get abdominal pain. Why did you get abdominal pain? Because your intestines swell. The big issue here is that it's not itchy and steroids won't work. Little minor trauma causing your face to explode, but steroids won't work and they're not itchy. And that's how you're going to tell it apart from a standard allergic reaction. It's just not itchy. What's the most common wrong answer? Saying steroids. Hereditary angioedema swells your larynx and you get stridor, abdominal pain, because it swells your GI tract. Your intestines are actually swelling and causes abdominal pain, and the lack of response to steroids. So it's the difference between life and death, because if you mix this up with a standard allergic reaction and you say that I'm going to give them epinephrine and antihistamines and steroids instead of replacing C1 esterase, instead of giving them fresh frozen plasma, ecallantide, icatibant, ecallantide, or concentrated C1, you will kill the patient. How do we know they go to the ICU? Because there's respiratory problems. And whether it says stridor or hoarseness or shortness of breath, anybody with angioedema or an allergic reaction bad enough to cause blood pressure or respiratory equals ICU. Here, I'm on CCS, and I want to know, do I give them the first dose of medications or transfer the location? First dose, transfer. The answer is the first dose of medications for sure, because you give the first dose of medications and first test, then transfer the location, initiate therapy, then transfer. So you see, C1 esterase prevents the consumption. C1 esterase inhibitor prevents the consumption of complement C2 and C4. Now, there's very few times when I will actually say to you, I don't think you should learn the whole mechanism and the whole pathway. Very few times I'm going to say that. I would normally say, yeah, you should understand it, because once you understand it, you can understand everything forever and answer all the questions. And that's an exception. The complement pathway is an exception, because understanding the complement pathway is so difficult for most people. Step 3 is really just going to say, do you know the right thing to do? That's ethics. Ethics is right action. That's right action. Plato and Aristotle very concerned with ethics, meaning you may not understand it or why you do it, or you may not know it's a virtue, but you did the right thing for people. You have an ethical life. And what Aristotle said is you can't really get people to understand it, and Plato said you can't teach virtue. But what they did say is you can have a pattern of right behavior, a habit. So it's a habit. Virtue and vice are a habit of behavior. Step 3 is very much in line with Aristotelian ethics. I don't know what's there. I don't understand it, but I'm going to get a C2 and C4 level because they should be low. And I'm deficient in C1 esterase inhibitor because the inhibitor prevents the consumption. C1 esterase consumes C2 and 4, and if I don't have the inhibitor, I consumed all the C2 and 4. So what am I going to do? White count is nonspecific. I'm going to measure these, and I'm going to give C1 esterase inhibitor. What does it do? I don't know. It inhibits C1 esterase. So in acute episodes, you actually can give concentrated C1 esterase inhibitor for anybody who has respiratory problems, facial problems, hypotension, or recombinant. Neither concentrated from pooled plasma or you make it. So you're missing C1 esterase inhibitor, so I gave you C1 esterase inhibitor. Yeah. Now, ecallantide stops the kallikrein. Now, this is where people start to have a seizure. This is why I gave you all this thing about Aristotle, which is you don't have to understand it, you just have to have a pattern of behavior. Just have a habit. And the habit is I know that I'm going to replace the C1 esterase inhibitor and give ecallantide. Why? Because ecallantide creates bradykinin. Kallikrein creates bradykinin. So if you inhibit the kallikrein, you're not breaking bradykinin. Bradykinin, slow action. It's a vasodilator. I wish they call it vasodilakinin. So fresh frozen plasma. Why am I giving fresh frozen plasma? Because it has C1 esterase inhibitor in it. So we can give it concentrated, and if we can't get it concentrated, or the C1 esterase inhibitor is not in the choice, fresh frozen plasma has the C1 esterase inhibitor. Ecallantide inhibits kallikrein. So what? Kallikrein makes the bradykinin. So what? Bradykinin is what causes all the vasodilation. So what's the bottom line? Ecallantide and icatibant stop the bradykinin and unswell your face. Chronic episodes or recurrences, preventing it. Why do androgens upgrade the amount of C1 esterase inhibitor? Because they do. How do you know it's an androgen? Because of the names. Danazol and stanazole. Dan and Stan are in man. Mandrogens. Great name. They raise the C1 esterase inhibitors. Dan and Stan. Oh, these drugs, tranexamic acid and aminocaproic acid. Big words. They hurt my brain. Tranexamic acid and aminocaproic acid. Stay with me. Don't have a seizure, please. Tranexamic acid and aminocaproic acid are medications, substances that inhibit fibrinolysis, the lysis of fibrin. Well, in coronary disease, we give thrombolytics because we want to lyse the fibrin. But if you have a person, for instance, with platelet disorders, like Bernard-Soulier syndrome, Glanzmann's thrombasthenia, and in one sense, these disorders of hereditary angioedema, these fibrinolysis inhibitors actually help prevent episodes of hereditary angioedema and your facial exploding. They work to prevent fibrin from breaking apart, so they keep your platelets together. They keep things tight. So what are they? They're tighteners. They're tighteners. Or you can just give concentrates of C1 esterase inhibitor all the time. Ecallantide, we said, blocks kallikrein. Kallikrein makes the bradykinin. Bradykinin makes your face swell. So you said, Conrad, I'm going into orthopedic surgery. This is why I went into psychiatry. I'm going into psychiatry so I don't have to learn about ecallantide and kallikrein and bradykinin. Dude, what do you think, if I get asked a question, what do you think the most likely question is going to be? Okay, here we go. The most likely question is someone has hereditary angioedema. It's very easy to mix up with an allergic reaction to peanuts and shellfish and penicillin. And so you just have to know that antihistamines, steroids, and epinephrine, the three standards of care in anaphylaxis, are not effective in hereditary angioedema. Well, how am I going to know that swollen ass face is not? How am I going to know that swollen face is not an allergic reaction? Very simple. Ready? Hereditary angioedema doesn't happen from taking a medication, doesn't happen from an insect bite, it doesn't happen from a food. It happens from minor trauma, exploding it. That's how you'll know. So these substances are not useful, and that's the single most important thing. They're for anaphylaxis, not for C1 esterase inhibitor. All right. Prophylaxis. Okay, you're going to have, a dental procedure? Yeah, isn't that like a minor trauma? Well, minor if it's not my dental procedures, but it's not like somebody's smacking you in the head with a bat. And what you do is you say, well, you want to prevent this sudden non-pruritic, non-itchy swelling. And what will you give before the procedure? And the answer is you give a version of what we just said is treatment. And the things that we said is treatment is fibrinolytics, antifibrinolytics, tranexamic acid, and aminocaproic acid. They prevent the breakdown of fibrin. Fibrin makes clots, fibrin holds platelets together, so the fibrin makes things tighter. Androgens, DAN and STAN, upgrade C1 esterase inhibitor levels, or you can actually give some infusions of C1 esterase inhibitors so your face doesn't explode. On to the next subject. A man comes with neurosyphilis, and he has anaphylaxis to penicillin. And as you know, if there is no good substitute for penicillin for neurosyphilis, because ceftriaxone and doxycycline don't get into high enough concentrations in the brain. And you're about to be desensitized. Now, desensitization means that you give small doses of the substance and then give a little more, and a little more, and a little more. And what happens is your body gets used to it. It's rather like cognitive behavioral therapy. You don't like getting on planes, do a little more, a little more, a little more. You get used to it. So how will you know if it's going wrong? I'm giving you the increasing doses of penicillin. How do you know it's going wrong? How do you know it's failed? The answer is they develop anaphylaxis. That's how you know it's failed. You're allergic to penicillin. All of a sudden you have hypotension, respiratory distress, you can't breathe. So what are you going to do before you manage this person? Use ceftriaxone. Ceftriaxone is not effective enough. The other thing is we just said it's anaphylaxis. So we learned from the 57 times I said it in the ID section is that if you have a rash to penicillin, you could use a cephalosporin. But if you have anaphylaxis, you shouldn't use a cephalosporin. Stop the propranolol. Well, remember, there's very few uses for propranolol. Stage fright, essential tremor, thyroid storm. Bolus with steroids prior to penicillin use. That's kind of an interesting thing. Maybe that'll help. So we're supposed to stop propranolol. Why? Well, if you go too far with the desensitization and they develop anaphylaxis. What's the treatment for anaphylaxis first? Epinephrine. But if you're on propranolol, the epinephrine's not going to work. Now, this point about stopping beta blockers before desensitization, because how do you know if the desensitization fails? Desensitization should work in almost everybody, but how do you know if it fails? They develop anaphylaxis. And you're supposed to be sitting there with the injector and with the syringe of epinephrine, so if it fails, you can give them the epinephrine. Now, allergists think everybody knows this, and is one of the top 5 questions you're going to be asked. This is one of the other top 5s with allergic rhinitis. I'm sneezy, I'm itchy. It's the itchy and scratchy and itchy sneezy. So nasal itching, nasal sneezing, snuffiness, rhinorrhea, runny nose, lots of paroxysms, and your eye itching too, because they're very connected. Okay, allergic rhinitis. You don't need to study it because half of you have it. So what are you going to ask me about it? Oh, I'm going to ask you what to do about it. I'm going to ask you what to do about it. Well, people who are allergic and hypersensitive, remember we said those medications? There are certain drugs like penicillin, sulfa drugs, allopurinol, phenytoin, rifampin, quinidine, and lamotrigine that are irritating everywhere. Well, there are certain people that are hypersensitive to everything. For instance, people who have asthma are more likely to have atopic diseases, are more likely to have eczema, are more likely to be sensitive everywhere, and that is why it is that the people who have allergic rhinitis are more likely to have skin and eye and other signs of atopic illnesses. The same way that they're more likely to have pernicious anemia later in life because I make antibodies against my stomach, or I'm more likely to have vitiligo. Okay, because I'm making antibodies against my melanocytes. I'm more likely to have Hashimoto's thyroiditis, vitiligo, pernicious anemia, Addison's disease. Don't they all fit together? I'm a hazard to myself. Don't let me get me, because I'm making antibodies not just to my lung, to my skin, to my eyes, to my nose. This is a GYN exam. This is the cervix. No, those are nasal turbinates. And what do you do if you get stuffy in nasal terminates? You basically avoid what you're allergic to. You avoid what you're allergic to, and you use inhaled steroids. Inhaled steroids stops the degranulation. Inhaled steroids eliminates or decreases the need for antihistamines. Now, when you have, let's see, and you're allergic to things in your environment like your sheets and your pillows because they have mites and dust and allergen, mites and dusts and allergen in your sheets and your pillows and your pillowcases, it's like housekeeping STD. Housekeeping STD? Yeah, it's like your pillow and your sheets have chlamydia or gonorrhea and you're allergic to it. So let's see, if you're with someone and the man, el hombre, tiene gonorrhea, can you get rid of it by just washing it? You can avoid it, but you cannot wash the chlamydia out of the penis. Vacuuming it? No, you cannot vacuum the chlamydia and the gonorrhea out of the penis. No, can you heat it up? No, you cannot cook the chlamydia and the gonorrhea. What you do if you have mites and dust and allergens on your sheets and pillows is, 1, avoiding your heavy petting, avoiding the pet, but you must cover the penis. So it's very much like a mattress STD. Washing it doesn't work, vacuuming it doesn't work, heating it up doesn't work, but covering will work. And that prevents you from having the the allergies to the exposure to the mites and the dust. And if you can't avoid the allergen exposure to the mites and the dust because you have red, itchy, watery eyes and sneezy and congestion, you're going to treat with topical steroids, inhaled intranasal steroids, antihistamines, but unlike anaphylaxis, in anaphylaxis you use H1 blockers that are sedating, diphenhydramine, hydroxyzine. Here, loratadine, fexofenadine, cetirizine, okay? And you'll use these medications. And remember, step 3 CCS will take the brand names. So if all you know is about Zyrtec and Claritin, they will take those for a CCS case. and inhaled antihistamines like azolastine. Cromolyn will work because you're preventing degranulation of mast cells. But if you just have to know one thing, then you'll say intranasal corticosteroids, transformed allergic rhinitis, much easier. And medications like montelukast will prevent leukotriene release and will prevent you from having allergic rhinitis. Isn't that fantastic? The same way for people who have their asthma from atopic illness, and they're having their asthma because they're allergic to things, montelukast is better. Now, for extra bonus points for the brand new car in the dream home in Los Angeles. Which vasculitis is associated with montelukast? Which vasculitis, which form of vasculitis is associated with montelukast? The artist formerly known as Churg-Strauss syndrome. Churg-Strauss syndrome, now known as allergic angiitis, my little neti pot, allergic angiitis, also known as the unbelievably long and painful term, granulomatosis with polyangiitis with eosinophils, eosinophilic GPA. Montelukast is associated with Churg-Strauss or eosinophilic GPA, but you use it for people who have very severe allergic rhinitis or asthma from atopic illnesses. Cromolyn and nidocromil only work to prevent, the same as it is in asthma. Montelukast only works to prevent, the same as it is in asthma. Inhaled steroids, intranasal steroids only work to prevent, the same as it is in asthma, the same as it is in asthma. They won't work after you've already had your release. Remember the dust mite and the mite thing? All you can do is cover up the mattresses and the pillows. And then what happens if there's something that you can't avoid? What happens if there's an allergen you can't avoid? And then it's cognitive behavioral therapy. Do you understand why you're scared of that dust? Yes, I understand it. I was scared by dust when I was a child. My father looked like a big dust. My father looked like a mite. So you understand it. Okay, so you can do it. No, I'm not doing it! Cognitive behavioral therapy is this. I don't understand anything about anything, but I'm going to do the right action. I don't understand anything about anything, but I'm going to do the right action. I'm going to desensitize myself. Don't you want to understand it? Ooh, understanding is not as important as right action. Cognitive behavioral therapy. Aristotle's ethics. Take the action. Desensitize. Virtue cannot be taught, but you can make it a habit and become a virtuous person by taking virtuous actions. Aristotle would have been a big fan of desensitization. Primary Immunodeficiency Syndromes in 10 minutes or less by Conrad Fischer. I don't want to understand very much, I just want to get the answers right. So no matter what the primary immunodeficiency syndrome is, I bet you get infections. No matter what the primary immunodeficiency syndrome is, I bet you treat the infections as they arise. No matter what the immunodeficiency syndrome is, well, where do we become allergic? Not so much in our butts, because we're not inhaling or eating in our butts, but in our respiratory syndrome system, because that's where we inhale things, including our bacteria. And if our immune system's not working, where we contact the outside world, like our mouths and our respiratory system becomes diseased. So, common variable immunodeficiency. Man, when I was in your position, I didn't understand any of these. Common variable immunodeficiency, X-linked agammaglobulinemia, hyper IgE. Man, I couldn't get any of them. But I'll tell you, it's called common because it is the most common. It's called variable because sometimes you're deficient in IgG, sometimes you're deficient in IgA. Common variable. It's called variable because sometimes it doesn't show up with symptoms until you're 20 or 30 or 40. So it might show up when you're 10, it might 30, 40. Now, X-linked, genetic, that shows up when you're a kid. X-linked means it shows up in boys more. It shows up in boys because just like Turner syndrome, when you're missing the other egg, or hemophilia, X-linked, you got to be homozygous in a woman. You have to be homozygous in a woman. Whereas X-linked things show up more often in male children. Common variable, because it could be deficiency of IgAs or IgGs. Common variable, because it might show up when you're 10, 20, 30, and 40. X-linked genetic, man, that is from birth. That is from birth. You know what I mean? They say, beauty is only skin deep. Yeah, but ugly goes to the bone. So X-linked things that are genetic start from birth. So this one could be both men and women. X-linked agammaglobulinemia is only in men because you'd have to be homozygous in the woman. May present when you're an adult, and also when the symptoms happen where you're in contact with the outside world, where you breathe in and in your respiratory systems. Sinusitis, bronchitis. Now this manifestation of the respiratory system symptoms also happens in X-linked agammaglobulinemia, so-called Bruton's agammaglobulinemia. So this part about recurrent sinopulmonary infections does not distinguish it between common variable and X-linked. What distinguishes it is that common variable, you have lymph nodes, you have adenoids, you have tonsils, you have T cells and B cells, but they don't make the immunoglobulins. You have the equipment, you have the B cells, you have the adenoids, you have the tonsils, but they're not making immunoglobulins. X-linked agammaglobulinemia, you don't have the equipment to make the immunoglobulins. Sprue-like. Why are you getting a sprue-like? Why are you getting malabsorption, steatorrhea, diarrhea? I just said the same thing in 3 different ways. Okay, because malabsorption gives steatorrhea, and steatorrhea is a type of diarrhea. You have the lymph nodes, you have the adenoids, you have the spleen. You get these abnormalities because this is part of being deficient often in IgA, and IgA protects your gut. IgA protects your sino-respiratory symptoms, sino-respiratory system, sino-respiratory tracts. So, in common variable, you have the B cells, but they're not making enough antibody. X-linked, you're not having the B cells. The total IgG levels are low, but it's also low in X-linked agammaglobulinemia, so-called Bruton's agammaglobulinemia. So the respiratory infections and the decreased IgG levels are low in both of them, but one has the B cells, the lymph nodes, the spleen, the adenoids, and one does not. The treatment ends up being the same for both. Treat the infections as they come along and give intravenous immunoglobulins. X-linked agammaglobulinemia, hey, it's genetic. Ugly goes to the bone right from birth. X-linked must be in boys, male children. Agammaglobulinemia. Well, I have no immunoglobulins made, but I also don't have the equipment to make them. I don't have the B cells. I don't have the adenoids. I don't have the spleen. And since I don't have the equipment, I'm not making the immunoglobulins. So I treat the infections as they come along and give intravenous immunoglobulins. This part about the levels being low, giving intravenous immunoglobulins, is the same. So what's the difference? The difference is gender and age of onset. IgA deficiency is actually the most common. It's a good thing it's the most common because it's the most benign. And most are asymptomatic because IgA you can live without the most. Oh my goodness, how a surprise. You have recurrent sinopulmonary infections because you can't handle things that are coming in from the outside world, and that includes also in your GI tract because your bowels have a very specific nervous system, and they have also a very specific immune system. That's why your bowels have automaticity with this very specific nervous system, and your bowels have Peyer's patches, which we can now specifically inhibit for people who have things like inflammatory bowel disease and for Crohn's disease. But this means also if you don't have that immune system in your bowel, you have a malabsorption because your bowel's immune system is missing. What's the treatment? There really isn't any. There isn't much in the way of specific therapy because we don't have a specific IgA replacement. We don't have intravenous IgA. We only have intravenous IgG. IgA, atopic. IgA, you get anaphylaxis. Why do you get anaphylaxis? Because the same way if you're blood group A, you make antibodies against blood group B. And if you're blood group B, you make antibodies against blood group A. Well, if you don't have IgA, you're making antibodies against IgA, and that's why you get anaphylaxis after a blood transfusion. You treat the infections as they arise, and there's just not much to do, because even the IVIG, not only does it not help, it can actually cause anaphylaxis, because there's a teeny little amount of IgA in it. Hyper IgE syndrome. Job's syndrome. So in the book of Job, God and Satan are having an argument. And Satan says, oh, all these people, they love you because you give them stuff. You're bribing them. And God says, well, let's do a test. There's my servant Job. He loves me. He goes, Job loves you because he's a rich guy. And he goes, well, I'll tell you what you can do. You can send some plagues onto Job, and let's see if he rejects me or not. So what happens is they sent plagues of skin infections, boils, skin infections, and that's why this used to be called Job's syndrome, because it's abnormal immune functioning, so you have staphylococcal infections recurrently, lifelong, all the time, and you basically can't fight off the staph that's on your skin. Job's syndrome. So the management is to treat the staph infections as they arise, and the main thing is for you to understand that hyper IgE, and Job does lay by the roadside and scrape his boils off his skin and the infections with shards of pottery. Ugh, let's see that again. That was really disgusting. Ay, ay, ay. Nothing you can do about this one. All of the immune deficiency syndromes in 10 minutes. I hope you're feeling a sense of accomplishment. Good job, I love you!